Okay, well, thank you very much, everybody, for coming. My name is Dr. Levy, and this evening we're going to be doing 2 cases of neurology, as Barb mentioned, and then we'll be going on to do rheumatology. The way I like to run these classes is I like to make them as interactive as possible. So I'm going to be asking a lot of questions, and I want you to try to answer the questions as much as you possibly can. The idea behind that basically is that I want you to be engaged actively in the learning process rather than me sitting up at the front lecturing you. And in that way, I think you'll understand the material a lot better. You'll have a lot better grasp of what what you should know for the step 3, and you'll learn it a lot better, and it'll be a lot more fun. And you won't be so tired, and so it won't be so difficult for you to learn the stuff. Does anybody have any questions? No questions. Okay. So let's go ahead and start with case 13. Okay. Chief complaint of unsteady gait. The patient is a 65-year-old man without significant medical history who comes in for evaluation of his gait. He and his wife attributed his problem initially to the natural course of aging, but now he seems to be just generally slow. On further questioning, he admits to increasing difficulty with his writing, which has become increasingly harder to read. So, just reading that history of present illness, what is the most likely diagnosis in this particular case? Parkinson's disease. Okay, very good. Now, why is that the most likely diagnosis? That's probably the harder question. The idea here is that when you're looking at a question on the USMLE, you have to be able to say why something is the most likely diagnosis rather than just being able to identify it. So what in the history tells you that this is actually Parkinson's disease? Can anybody tell me? What? Okay, so the slow gait. Now, is slow gait specific for Parkinson's disease? Now, can somebody who has, let's say, a cerebellar stroke, could they have ataxia and have a slow gait? Yeah, right? Can somebody who has normal pressure hydrocephalus, could they have dementia, incontinence, and a slow gait or ataxia? Yeah. So there's a number of diagnoses that can give you a slow gait or ataxia, and it's not really specific for Parkinson's. It's part of sort of the symptomatology that Parkinson's can present with, but it's not specific. What else in the history gives you? The what? The age? Okay, do younger people get Parkinson's disease? Yeah, it's possible, right? So the age doesn't really tell you either. It may suggest it, but it's not really specific. Anything else in the history? Okay, so the writing, the micrographia, right? That's what that's called, is that when patients have Parkinson's disease, they have difficulty writing they write very, 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 very small. Now, the main thing here, the key word here is generally slow. That this is a patient who has ataxia or gait problem, but who also has micrographia, which is also suggestive of Parkinson's disease, but in addition to everything is just generally slow. And what is that called in Parkinson's disease? Bradykinesia, right? And that's actually one of the cardinal manifestations of Parkinson's disease. The patients just generally feel very slow. They don't move very quickly. They may describe having difficulty getting up in the morning, having difficulty dressing properly or dressing in time, and having difficulty essentially doing all the activities that we take for granted simply because it takes so much time for them to do it. So that's actually one of the cardinal manifestations of Parkinson's disease. What are the other cardinal manifestations of Parkinson's disease? Okay, resting tremor is another one. What else? Okay, right, postural, cogwheel rigidity. What else? What? Shuffling gait? Perhaps, but what's a better term for shuffling gait rather than shuffling gait? Well, postural instability, right? They have postural instability. And a good mnemonic that I like to use is BRIT. Parkinson is a British name, so BRIT is a nice mnemonic sort of for the cardinal manifestations of Parkinson's disease. B stands for bradykinesia, right? R stands for rigidity. I stands for instability or postural instability. And T stands for resting tremor. right? And those are really the cardinal manifestations of Parkinson's disease. Now, how do we make the diagnosis of Parkinson's disease? Is it a clinical diagnosis? Are there any tests that we can do to make the diagnosis? It's a clinical diagnosis. In fact, Parkinson's disease is a pathologic diagnosis, meaning that you can only make the diagnosis of Parkinson's disease if you have tissue and you've documented decreased dopaminergic neurons in the striatum nigra, right? Now, so when we talk about Parkinson's disease, we're really talking about Parkinsonism, which is a clinical diagnosis based upon these sort of these four manifestations that we had been discussing. Now, what is the first step in actually evaluating a patient who presents with Parkinsonism? Can anybody tell me? The first step in evaluating a patient with Parkinsonism. What's the first question that you really have to answer for yourself when a patient presents with resting tremor or, shuffling gait or postural instability or bradykinesia? What's the first question that you have to answer for yourself? Well, you have to answer, is this Parkinsonism idiopathic? Meaning, or is there another cause or something that the patient's doing or another disease that the patient's having that's causing him to have Parkinsonism, right? So what are causes of Parkinsonism? Vascular disease, okay? So vascular disease can cause anything. Anything in the midbrain where those dopaminergic neurons are, whether it's a brain tumor, whether it's an infarct, whether it's a CVA, can cause Parkinson's disease, right? So you have to exclude any sort of anatomic cause of Parkinson's disease, right? What else can cause Parkinsonism? Drugs. Classically what? Antipsychotics, right? Such as Haldol, Haloperidol. Any antipsychotic medication can actually cause Parkinsonism. What other medications can cause Parkinsonism? What? Reserpine, correct. What else? NPTP is a poison. Well, we're going to get to that. But what medications, what common medication can cause Parkinson's disease? Let's say a 45-year-old female comes in who has a history of diabetes and gastric paresis, metoclopramide. Okay, so that also can cause Parkinson's disease. So you have to consider medication as a primary cause of Parkinsonism. You have to consider cerebrovascular disease or brain tumor or any sort of anatomic cause of Parkinsonism. What else can cause Parkinsonism? You mentioned before. What? Viruses, not really commonly, but poisons, toxins. What kind of toxins? What kind of toxins can cause Parkinsonism? NPTP, what else? Carbon monoxide, very good. What else? Carbon monoxide, NPTP, what else? Let's see, can I think of something? Carbon monoxide, NPTP, organophosphates can also cause Parkinsonism. Okay, so organophosphates, which are usually found in, when they're spraying vegetables to get rid of all of the insects, you use organophosphates for that, and that can actually cause Parkinsonism, right? So this is a gentleman who basically comes in with bradykinesia, slow gait. We don't know if he has a resting tremor, but he has micrographia. And the first question you really have to ask yourself is there a secondary cause? Is there something else causing his Parkinsonism before you label him as having Parkinsonism, which is idiopathic? All right? So what do you expect to find on physical exam? What do you expect to find on physical exam? Well, what are the four cardinal manifestations of Parkinson's disease? Okay, so you expect to find maybe some cogwheel rigidity, resting tremor, bradykinesia. How is bradykinesia manifest? What do you find on physical exam or history? Well, they have difficulty getting up out of a chair, right? They walk with the small, steps. They have mask facies. That's also a manifestation of bradykinesia. The micrographia is also a manifestation of bradykinesia. So bradykinesia is sort of this, large thing which includes a lot of the classic signs of Parkinson's disease. Okay, so let's go to the physical exam, and let's see what we find. And we'll see if our findings are correct, our expectations are correct. So the patient has little facial expression, right, and decrease in the eye blink. Resting tremor that resolves with movement. Now, how is cerebellar disease, how is the tremor of cerebellar disease different from this tremor? So a patient who had a cerebellar stroke, let's say, or who has a tumor in the cerebellum, how would his tremor be different from the tremor of Parkinson's disease? Okay, it's intention tremor, so it's exactly the opposite. In Parkinson's disease, the tremor is very evident when the patient is at rest and not moving, and then when he moves, the tremor goes away. In cerebellar disease, there's no tremor when the patient's not moving, and only when he begins to move does he get the tremor. So it's the opposite. In Parkinson's disease, you have a resting tremor which gets suppressed with movement, and in cerebellar disease, you have no resting tremor, and the tremor actually gets aggravated with movement. So he has a resting tremor that seems to resolve when he moves, when he points at something, and when he moves his hand. Cogwheel rigidity with parotonia. He has micrographia, as we discussed, which is a manifestation of bradykinesia, and he has decrease in rapid alternative movements. He walks with a shuffling gait, and he has profound retropulsion. No sensory abnormalities are noted. Now, what is retropulsion? What is retropulsion? Can anybody tell me what retropulsion is? What is retropulsion? Think about it. And I'll ask you again. Retropulsion. What is propulsion? Well, when you move forward, right? And what's retropulsion? When you move backwards. So if I can have a volunteer from the audience, somebody from the front row who wants to come and help me to show, come. You. Just come. Not a big deal. Don't worry, I don't bite. I'm not going to hit you. Nothing's going to happen. Just need your help for a second. Okay, so I'm going to stand. I'm going to ask you. I'm going to stand like this. Now, usually when you stand like this and you close your eyes and somebody pushes you back suddenly, what happens? So push me back suddenly. Back. No. Back. This way. Okay? So what happens is that I fall back, but I regain my balance. I have the ability to regain my balance. What happens in Parkinson's disease? Try again. Okay? I just keep going and going and going as long as my microphone will let me. Back and back and back. That's retropulsion, and that's postural instability. So patients with Parkinson's, thank you, I'm done. So patients with Parkinson's have retropulsion as a manifestation of their postural instability. All right. So we've gone over the primary manifestations of the disease. We've discussed secondary Parkinsonism, which is important to exclude when making the diagnosis of idiopathic Parkinsonism. So what we have left to discuss really is the management and the treatment of patients with Parkinson's disease. So how do we treat Parkinson's disease? What's the first question that you have to ask yourself when you're trying to determine how to treat somebody with Parkinson's disease? Well, what drugs do we use? Slow it out. What drugs do we use? Levodopa, carbidopa, right? Sinemet, right? Now, do we always use Sinemet? Did every single patient who comes in complaining of Parkinsonism get Sinemet right off the bat? No. Why not? Why not? Anybody know why not? The answer is no. Not all patients who have Parkinson's right away gets Sinemet right away. And why is that? Well, the side effects, right? There's a lot of side effects to giving dopaminergic agonists. What are the side effects of Sinemet? Psychosis. What else? Can actually cause orthostatic hypotension. And there's a lot of GI upset. Now, in addition, patients who get carbidopa, levodopa can have something called the on-off phenomena, where the levels in their blood fluctuate very extremely, and they turn on and off. So they're Parkinson. They have, they're very Parkinsonian 1 second, and then 5 minutes later they're well, and then they become Parkinsonian again. So that can be very, very difficult for patients. They also can get dyskinesias, which are abnormal movements of the muscles. That can happen as well. So the side effect profile for Sinemet is not the greatest one, and in fact, we try to avoid giving the Sinemet as much as possible. So when do we decide? When do we decide to start Sinemet? When do we start carbidopa, levodopa? For example, in our particular patient, he comes in. He has his bradykinesia. He has his shuffling gait, and his cognitive rigidity, what is the question that you need to ask in order to make the decision about whether you're going to give this patient Sinemet or not? Anybody know? Anybody know? Well, it's actually functional capacity. How functional is the patient? Meaning, is his Parkinson's disease, has this disease progressed to the point where he can't function satisfactorily in his daily living? So if a patient has functional impairment because of his Parkinson's disease, that is the major indication to start therapy with levodopa-carbidopa. Because only up until that point, only at that point are we willing to risk the side effect profile and all the complications that come with that therapy. Only at that point are we willing to risk that side effect profile because his disease has progressed to the point where he can't function anymore. So if a person's not functioning, we're willing to risk a few side effects. However, if a person is functioning basically okay, they're able to function in their daily life, they can walk, they can get dressed, they can cook, they can do everything that they need to do to live, we don't go and give the Sinemet or the carbidopa-levodopa. So how do we treat patients who come in with good functional capacity but who have Parkinson's disease? How do we treat them? What other medications can we use to treat Parkinson's disease? What other medications? Okay, anybody heard of amantadine? Okay, so you can use amantadine, and you can actually use anticholinergic medication. Now, the thing with amantadine and anticholinergic medication is that those medications are really, really good for tremor, but not really good for bradykinesia. So if a patient has good functional capacity, but has a resting tremor that is distressing to him or herself, we generally start with amantadine or anticholinergic medications. Now, how do we choose between giving amantadine or giving anticholinergic medications? Well, what sort of group of people don't do well on anticholinergic medications? Old people, okay? So an elderly person who comes in with Parkinson's disease but is not functionally impaired, but has a resting tremor and we want to treat with the medication, we're not going to give carbidopa-levodopa because their functional impairment, there's no functional impairment. What are we going to give them? We're not going to give them anticholinergic medication because that can cause dementia and urinary retention. And the side effects in elderly people of anticholinergic medications are very, very, very bad. So what do we give such a patient? We give him amantadine. So when do we give the anticholinergics in the treatment of Parkinson's disease with no functional impairment? When do we give anticholinergic medication? In younger patients. So younger patients who have no functional impairment secondary to their Parkinson's disease and have a resting tremor, we give anticholinergic medication. In older patients who have no functional impairment due to their Parkinson's disease but have a tremor, we give amantadine. And to patients who have functional impairment secondary to their Parkinson's disease, the first-line treatment is carbidopa-levodopa, Sinemet. Okay. So, we've gone over the basic algorithm of how to manage Parkinson's disease, but we've left out a number of medications. What other classes of medications are there to treat Parkinson's disease? What? Okay, selegiline. Now, selegiline is the one anti-Parkinsonian medication that has been thought to actually arrest the progression of the disease. Now, the data that supports this contention is really not there. There is still some doubt whether it actually arrests progression. The reason why you should know about selegiline is if for any reason you find on the boards a question about arresting the progression of Parkinson's disease, even though the data is not that clear, the best answer to that question is selegiline. All right? So even though, in fact, the data is not that strong and it's unclear whether it actually arrests the progression, if you are asked that question on the board, it's important to know that you're going to answer selegiline even though the data is not clear. Because out of all the anti-Parkinsonian medications that we can give, selegiline is the only one where there is even a thought of the possibility that perhaps it may arrest the progression of the disease. All right? What other medications can we give for the treatment of Parkinson's disease? Bromocriptine, which is a what? Which is what? What's the class? Okay, it's a dopamine agonist, right? So bromocriptine is a dopamine agonist. What other dopaminergic agonists can you think of? Pergolide, right? Right? There are a couple that are new generations, which are called one of them is called pramipexole, and one of them is called ropinirole. Now, what's the difference between the earlier dopaminergic agonists and the later ones? What's the difference? Side effects. Okay, very good. That's a good answer always when you're talking about drugs. So, side effects. But what in particular? Which side effect in particular? Okay, well, bromocriptine and pergolide are ergoid alkaloids, right? And what do ergoid alkaloids do? They cause vasoconstriction, right? That's why we treat them to treat migraines and cluster headaches, right? The pathophysiology of migraine headache is that you have vasodilatation. And you give the ergoid alkaloid to vasoconstrict and actually improve the headache, right? Now, can anybody think of any disease states where vasoconstriction would be a problem? What? Angina, any sort of coronary artery disease, right? Because if a person has a 70% lesion in the left anterior descending artery, and you give them a medication for the Parkinson's disease that will constrict that artery, oops, I've just caused a myocardial infarction. That's not good, right? So the relative contraindication, or the absolute contraindication, really, to giving these ergoid alkaloids, like bromocriptine and pergolide, is a history of coronary artery disease, a history of peripheral vascular disease, a history of cerebral vascular disease. And this applies to migraine and cluster headaches as well. You should know that these medications are relatively contraindicated in patients who have these diseases, and you must stress these patients, you must do a stress test, even if they have risk factors for coronary artery disease, before you prescribe them these medications. Now, sumatriptan is the same thing. Giving sumatriptan, just getting back to migraine to be complete, giving sumatriptan to a patient with coronary artery disease is actually a problem because you can cause vasoconstriction and you can induce a myocardial infarction. So there's a relative contraindication to giving these ergoid alkaloids in Parkinson's patients because a lot of them are elderly and a lot of them have other comorbidities. They're not the greatest medications to give. They cause orthostatic hypotension, and they're not really that good. But pramipexole and ropinirole, which are the newer generation dopaminergic agonists, don't have this effect or these effects that the earlier ones do. So just be aware that there's a relative contraindication or that there's a concern. Don't rush to give ergoid alkaloids to your elderly patients who have diabetes and hypertension and high cholesterol. Be aware that you have to stress them, you have to do a stress test, you have to rule out coronary artery disease before you actually give them these medications. Now, what is the role of the dopaminergic agonists in the treatment of Parkinson's disease? What's the role of the dopaminergic agonist? When do we give it? When do we give dopaminergic agonists in the treatment of Parkinson's disease? When? End stage? Well, actually, we use it sort of as a, we were talking before about the on-off phenomenon in Parkinson's, right? That the levels of the Cinemet can actually fluctuate up and down and up and down and up and down. So let's say you had a patient on the boards, a 65-year-old man, who comes in with Parkinson's disease, who's experiencing on-off phenomena. What can you do to actually, there are three things that you can do to actually help him get over or help him manage this on-off phenomena. What are those three things? What are those three things? Well, you can actually go down on the individual dose of the Cinemet and spread it out over more doses over the course of the day to try to normalize the blood levels of the medication. That's one thing that you can do. What else can you do? Usually, Cinemet is absorbed from the gut, and when people eat high-protein meals, they can absorb less Cinemet from the gut, and it can result in more fluctuations. So you have to make sure the patient's not having a high-protein diet and ask them to cut down on the protein a little bit when they're taking their Cinemet. What's the third thing that you can do? You can give dopaminergic agonists. Sort of as a plug, you're sticking your thumb, that story of the little Dutch boy who sticks his finger in the dam so the water doesn't come through? It's the same thing. Patients are breaking through their Cinemet therapy, and you're giving them the dopamine agonist sort of to help them get over the off period till they get back onto the on period. All right? So that's one of the problems that come with giving Sinemet or giving levodopa carbidopa is that you have this on-off phenomena. And there's three things that you can do. You can space the doses of the Sinemet better, meaning you give a lower dose more frequently. You can give a dopaminergic agonist to sort of, help them with their off phenomena when it does occur, and you can make sure that they're taking a low-protein diet so the Sinemet is being absorbed at a sort of a nice rate and at a basal level. What other problems are there with carbidopa and levodopa therapy? We said psychosis, right? So if on the boards they ask you, a patient comes in with a history of Parkinson's disease and is having hallucinations, is having insomnia, is seeing things, hearing voices, whatever it is acting acutely psychotic, there's two things that you can do. What can you do? Well, if the carbidopa-levodopa is giving the patient psychosis, you can go down on the medication that's giving them the psychosis and hope that the psychosis will go away. So you can go down on the medication, or you can give an antipsychotic medication. Which antipsychotic medication is the best medication to give in Parkinson's patients? Well, again, you're looking for an antipsychotic medication that doesn't give you Parkinsonism, right? Because you wouldn't want to give a patient with Parkinson's haloperidol, right? You can give atypical antipsychotics, right? And the answer on the boards is clozapine, actually. If you're looking for an antipsychotic to give to a Parkinsonian patient who's having acute psychosis from his Sinemet therapy, the answer is clozapine, or an atypical antipsychotic. Now, for dyskinesias, what do you do? What do you do for dyskinesias? These sort of abnormal muscular movements that patients with Parkinson's get? You simply go down on the medication. So Parkinson's disease, now this is the central issue really in the treatment, is how far can we go with the Sinemet without getting these awful side effects? And how much Sinemet does the patient need to make his Parkinson's better? And at what cost is it in terms of the side effects? And the management of Parkinson's disease is balancing these two needs. The need of the patient to be able to function on a daily basis, and the ability of the patient to tolerate therapy with Sinemet. Now, what's so special about Sinemet? Did we always have Sinemet? Did we always have carbidopa, levodopa? Has anybody ever seen the movie Awakenings? Ever seen the movie Awakenings with Robert De Niro? So how much dopamine were the patients in Awakenings getting? Gram, 2 grams, 3 grams, 4 grams a day, right? They were getting tremendous amounts of dopamine. Now, why do they require such a large dose of dopamine on a daily basis? Why? Right, the levodopa would get converted peripherally, it would never reach the brain. Right? So carbidopa is actually there simply to inhibit the peripheral conversion of levodopa so that it can be delivered to the brain. And why do we care about that? Is because we can give a much lower dose of the levodopa to have a central effect. We don't have to overcome the peripheral conversion. And we can give a much lower dose to have a central effect, and that actually was a huge advance in the treatment of Parkinson's disease. We have problems with the side effects, but the fact that we can give so much less levodopa, because we know that the levodopa that we're giving is actually going to reach the brain, is a huge advance in the treatment of Parkinson's disease. It's huge. So that's really the central issue. Okay, I think we can go on to the next case. Does anybody have any questions? Any questions? No questions. Okay, so let's go on to the next case. Okay. Now, just a quick thing, actually, about the Parkinsonian plus syndromes. Okay. Now, what you have to know about this stuff is basically how to recognize it. Right? What is supranuclear palsy? What is supranuclear palsy? It's Parkinsonism plus nuclear palsy or paralysis of the vertical movement of the eyes. So if a patient comes in with Parkinson's disease plus an inability to look up and down, an inability to move the eyes vertically, they have supranuclear palsy. They have supranuclear palsy. If a patient comes in with Parkinson's disease and has orthostatic hypotension, has autonomic dysfunction, what is that called? Shy-Drager syndrome. So Shy-Drager syndrome is simply Parkinsonism plus autonomic dysfunction. If a patient comes in with Parkinson's disease plus ataxia, what's that? Olivopontocerebellar degeneration. All right? So these are the Parkinsonian plus syndromes. And all you have to do is to be able to recognize them. Parkinson's plus autonomic dysfunction is Shy-Drager syndrome. Parkinson's plus vertical ophthalmoplegia is supranuclear palsy. Parkinson's plus ataxia is olivopontocerebellar degeneration. Now, what's characteristic about these Parkinsonian plus syndromes is that they don't respond to levodopa-carbidopa. The Parkinsonism does not respond to Sinemet therapy. And that's basically what you have to know about that stuff. All right, let's go on to the next case. Okay, so we're getting an MRI initially on this patient because of what he talked about earlier. The possibility of cerebrovascular disease, the possibility of a brain tumor actually causing the Parkinsonism. And it was normal. All right? And here's a little figure, the shuffling gait. All right? And we'll go on to the next case. Okay, so case 14. Chief complaint. Episodes of language difficulty and right-handed weakness. A 72-year-old man whose wife has noted that the patient had multiple episodes of difficulty speaking and understanding language, as well as multiple episodes of dropping objects held in his right hand. The problems have been developing slowly over a year. Now, what does that sentence tell you? The problems have been developing slowly over 1 year. What does it exclude, basically, in neurologic disease? A stroke, right? He may be having multi-infarcts. He may have chronic cerebrovascular disease, but we're not dealing with an acute event here. This is a patient who's had sort of a slow, chronic progression of his symptoms over the course of a year, and so we sort of can rule out an acute CVA as one of the diagnoses or as part of the differential diagnosis. All right? The patient is a former actor who appeared in a number of Western movies prior to giving up acting for a career as a politician. He and his wife have noted gradually increasing forgetfulness over the last year. He has recently been doing a lot of horseback riding. He denies headaches. All right. So, what is the most likely diagnosis here? So let's just summarize. You have a 72-year-old man who's had multiple episodes of difficulty speaking. He doesn't understand language as well. Okay? He's been dropping a lot of objects, and it's a chronic process. All right? With increasing forgetfulness and so on. All right? So the chief complaint is episodes of language difficulty and right-handed weakness. What's the most likely diagnosis here? Alzheimer's disease. Okay, well, why is it not Alzheimer's disease? Why is it not Alzheimer's disease? Well, actually, it could be Alzheimer's disease. Why is it less likely to be Alzheimer's disease for the purpose of the boards? What? Well, he's complaining of forgetfulness. That's memory, right? He's complaining of forgetfulness. So there is forgetfulness there. So there is some memory impairment. But what is the kicker? Why is this much less likely to be Alzheimer's disease than anything? Why is this less likely to be Alzheimer's disease? Right? He has a focal neurologic exam. He has right-sided weakness. Right? So any patient who has dementia with a focal neurologic exam, even though it's possible that it's Alzheimer's disease and maybe had an old stroke and so on, but for the sake of the board, or for the sake of the boards, they're not giving you the right-handed weakness to confuse you so much. So there's a difference between dementia with a non-focal neurologic exam and dementia with a focal neurologic exam. Right? And when we talk about working up patients with dementia, we talk about ruling out hypothyroidism, B12 deficiency, syphilis with an RPR, right? And we get a CT scan and an MRI. Now, why do we get a CT scan and an MRI as a workup for patients who come in with dementia? Precisely for this reason, that there are anatomic causes of dementia. Frontal lobe tumors can cause you can cause dementia. Now, I will tell you that it's very, very unlikely that a patient who has a tumor in his brain to have a non-focal exam. But it is possible. All right? But you have to distinguish between this case, which is dementia with a focal exam, and the earlier case of dementia that we had, where there was a non-focal exam. So when the exam is non-focal, the most likely diagnosis is Alzheimer's disease. But when the neurologic exam is focal, there's weakness, there's pronator drift, there's right lower extremity weakness, there's something, it's more likely to be some sort of anatomic cause causing the forgetfulness and causing the dementia. So that's really the key point in this case. Dementia plus focal neurologic exam is different than dementia with a non-focal neurologic exam. So he has a focal neurologic exam, it appears, and he is demented. So we're looking for an anatomic cause for his dementia. On physical exam, blood pressure is normal, everything's basically okay, except for he has some right hand leg weakness, okay, and calculations and judgment are intact, but short-term memory is poor. So he has a memory impairment with a focal neurologic exam. The most likely diagnosis is subdural hematoma or brain tumor or something anatomic causing the focal neurologic exam with the dementia. So, Alzheimer's disease, transient TIA, subdural hematoma, epidural hematoma. CVA is less likely, though he may have multi-infarct dementia. Now, to differentiate between multi-infarct dementia and Alzheimer's disease is practically very, very difficult, because most patients who have Alzheimer's disease also have risk factors for cerebrovascular disease. I will tell you, however, that classically, multi-infarct dementia will have this stepwise deterioration in the cognitive impairment. So only if the dementia or the cognitive impairment is closely associated with the stroke or with the cerebrovascular accident can you really say with a certain degree of clinical confidence that this patient has multi-infarct dementia. Otherwise, it becomes very, very difficult to distinguish between the two. All right, so you get the CT scan. And what does the CT scan show? What's the finding here? What is the finding here on the CT scan? Let me get my pointer out. Okay, so this is subdural hematoma. Okay, and basically what happens here is, if you remember in the history, the gentleman was was horseback riding a lot, and for what us is minor trauma, as the brain ages and shrinks, the bridging veins can be stretched. Even minor trauma can cause a chronic bleed. And how are you going to treat this anatomic problem? With an anatomic solution. You're going to actually drain the hematoma and see if the patient improves. All right, let's take a break and we'll come back.